Hello, good evening. In this session, we'll be dealing with the deep cervical fascia. So, deep cervical fascia is also called as fascia coli. So, what it actually does, it invests the muscles of the neck, fills the gaps between muscles, vessels, and cervical viscera. So, for studying purpose, we have divided this deep cervical fascia into three layers: investing layer of deep cervical fascia, pretracheal layer, and prevertebral layer. The space between pretracheal and prevertebral layer forms visceral compartment, and the carotid sheath forms a neurovascular compartment. We will see in detail about these layers in coming slides. So as you can see here, this entire layer in the periphery, what you are seeing here. So this particular layer is the investing layer. It invests everything in the neck. And if you observe in front of this vertebra, you can see there is a layer here. Again, this is also starting from the investing layer. This is the pre-vertebral layer. And here in front of the trachea, you can see again there is one more layer coming from the deeper aspect of the investing layer and continuing in front of the trachea. This is the pretracheal layer. So pretracheal layer, pre-vertebral layer, and investing layer. We will see this vertical disposition, horizontal disposition, and details about all this. So investing fascia, as you see here, it lies under cover of platysma. Attachments. So behind it is attached to ligamentum nuchae and seventh cervical spine. Okay. And in front, so it continues with the similar fascia of opposite side across the midline and is attached to hyoid bone. So if you see the attachments above, so let us start from behind and let us trace it forwards. So superiorly, let us start from external occipital protuberance. So it will have an attachment at external occipital protuberance. Then it will have attachment along the superior nuchal line of occipital bone. Then the mastoid part and its process of the temporal bone. Then the cartilaginous part of the external acoustic meatus. Then lower margin of the zygomatic arch and lower border of the body of mandible extending from angle of mandible to the symphysis mentae. Okay. So this is the attachment above. So we will start from external occipital protuberance and we will trace up to the symphysis mentae. So below, the same way we'll just trace it from behind forwards. Let us start it from the spine and acromial process of the scapula, then upper surface of the clavicle and suprasternal notch of manubrium sterni. So like this we trace it from spine and acromial process of scapula, then upper surface of clavicle and suprasternal notch of the manubrium sterni. So if we see the attachments of investing layer, so behind it is attached to the ligamentum nuchae and seventh cervical spine. In front, so it continues with the similar fascia of opposite side across the midline and it's attached to hyoid bone. And if you see above, when it trace it from behind forwards, so we'll start from external occipital protuberance, then superior nuchal line, then mastoid part and its process, then cartilaginous part of external acoustic meatus, then lower margin of zygomatic arch and lower border of the mandible extending from angle of mandible to the symphysis mentae. So below, again we'll trace it from behind forwards. It is the spine and acromial process of scapula, then upper surface of clavicle, then suprasternal notch of manubrium sterni. So now, if we trace the horizontal disposition, so from this diagram we can see here. So this is the ligamentum nuchae. So then it splits into two layers to enclose the trapezius muscle. And at the anterior border of the trapezius muscle, so it will unite to form a single layer of investing layer which forms the roof of the posterior triangle. Then again, once it reaches the posterior border of the sternocleidomastoid muscle, it splits into two layers to enclose the sternocleidomastoid muscle. And at the anterior border of the sternomastoid muscle, it becomes again a single layer forming the roof of the anterior triangle. So this is how we trace it. And here you can see the splitting of this investing layer to enclose the suprasternal space of Burns. So this is how we trace. Again, I'll trace it for you. Ligamentum nuchae, two layers to enclose the trapezius, then single layer to form the roof of posterior triangle, then again two layers to enclose the sternocleidomastoid, then again single layer to form the roof of the anterior triangle, and just above the sternum it will have two layers to enclose the suprasternal space of Burns. So ligamentum nuchae, trapezius, roof of posterior triangle, sternomastoid, and roof of anterior triangle. Now, if you see the vertical disposition, above it splits to enclose submandibular and parotid glands. So near the submandibular gland, there will be two layers. The superficial layer is attached to lower border of mandible and deep layer is attached to the mylohyoid line of mandible. Let us see here. So you can see here, this will be the submandibular gland. You can see here, this will be the superficial layer. This will be the deep layer. So deep layer attached to the mylohyoid line. The superficial layer is attached to the lower border of the mandible. Now, if you see here, again same thing. The uh, investing layer splits to enclose the parotid gland also. Again, there will be two layers here, the superficial layer and deep layer. You can see here, this will be the superficial layer. This will be the deep layer. The superficial layer is attached to zygomatic arch and epimysium of masseter. So here along with this, it forms perotidomasseteric fascia. This is the only deep fascia on the face. You can see here, this is the superficial layer attached to zygomatic arch, and also it fuses with the epimysium of masseter to form the perotidomasseteric fascia. And if you observe the deep layer, it is attached to the tympanic plate and styloid process. So here it forms the stylomandibular ligament between styloid process and the angle of mandible. So this ligament actually separates the parotid gland from submandibular gland and is pierced by the cervical part of the facial artery. You can see here, this is the deep layer. So this is attached to the tympanic plate, and here you can see the thickening to form the stylomandibular ligament. Stylomandibular ligament. This will be sometimes pierced by the cervical part of the facial artery. So this actually forms a partition between the parotid gland and the submandibular gland. So again, now if we trace this vertically below, so it splits to enclose two spaces. One is the suprasternal space of Burns. So I have shown here. See here, this is the suprasternal space of Burns. So suprasternal space of Burns, it is triangular space above the manubrium sterni. Fascia splits into two layers, the superficial and deep layer attached to the anterior and posterior borders of the suprasternal notch. The contents are sternal head of the sternomastoid or sternocleidomastoid and jugular venous arch connecting anterior jugular veins, interclavicular ligament and some lymph nodes. So you can see here, this is the jugular venous arch. You can see this is the jugular venous arch connecting the anterior jugular veins in the suprasternal space of Burns. Then again, above the middle third of the clavicle, this investing layer splits to enclose supraclavicular space. So there will be anterior and posterior borders of the upper surface of the clavicle, which gives respectively to attachment of the two layers of the investing fascia. So above the middle one third of the clavicle, the investing fascia splits into two layers and attached to the anterior and posterior border of the upper surface of clavicle. So this splitting encloses the supraclavicular space. The posterior layer encloses inferior belly of omohyoid muscle and forms omohyoid fascia. This is the classical view. So few authors contradict it that omohyoid fascia is superior extension of the posterior layer of clavipectoral fascia, and few authors believe that forward extension of the pretracheal fascia in front of introhyoid muscles forms the omohyoid fascia. So contents will be terminal part of the external jugular vein, supraclavicular nerves before they become cutaneous. You can see here, this is the investing layer splitting above the middle third of the clavicle to enclose the supraclavicular space, and you can see the posterior layer enclosing the inferior belly of omohyoid to form the omohyoid fascia. This is the classical view. Here you can see the extension of posterior layer of clavipectoral fascia to enclose the inferior belly of omohyoid to form the omohyoid fascia. So if we highlight what is happening with the investing layer, so it encloses two muscles, trapezius and sternomastoid, as I have shown in the diagram. You can see here it encloses two muscles, sternocleidomastoid and trapezius. So it forms roof of two triangles, namely the anterior and posterior triangles of neck. It encloses two glands like submandibular and parotid gland. So it thickens twice. One is it forms stylomandibular ligament. The other one is it forms perotidomasseteric fascia. So it also forms two facial slings. One is around the inferior belly of omohyoid. The other one is around the intermediate tendon of digastric muscles. And it encloses two spaces. One is the suprasternal space of Burns and the supraclavicular space. And it gives rise to two facial processes, namely the pretracheal and prevertebral layers. You can see in this diagram. So it is giving rise to two facial processes, pretracheal layer and prevertebral layer. So this pretracheal layer will form the anterior wall of carotid sheath and the prevertebral layer will form the posterior wall of the carotid sheath. This is about the investing layer. Now we'll go with the pretracheal layer. So let us trace it horizontally. Arises from the fascia under cover of sternomastoid, then forms the anterior wall of the carotid sheath, splits to enclose the thyroid gland and continues with similar layer of the opposite side. Ligament of Berry So this ligament connects the thyroid gland to the cricoid cartilage. So this is derived from the pretracheal fascia. You can see here, this is the ligament of Berry, which is derived from the pretracheal fascia. You can see this is the pretracheal fascia arising from the investing layer, then forming the anterior wall of the carotid sheath, then splitting to enclose the thyroid gland and continues with the similar layer. And you can also see the formation of the ligament of Berry, and you can see the recurrent laryngeal nerve in relation to the ligament of Berry. So then vertical deposition. So above it is attached to hyoid bone and oblique line of thyroid cartilage. So attachment of this fascia to hyoid bone, thyroid and cricoid cartilages moves the thyroid gland with deglutition. So any swelling in the neck, if it moves with deglutition, so most commonly it goes in favor of thyroid gland. So below enters thorax and blends with the fibrous pericardium of the heart. So you can see here, so it is attached to the hyoid bone as well as to the oblique line of the thyroid cartilage, and below you can see this is continuing with the fibrous pericardium of the heart. So prevertebral fascia, again horizontal disposition, arises from fascia and core of sternocleidomastoid, forms the posterior wall of carotid sheath, covers the cervical vertebra and prevertebral muscles, continues with similar fascia of the opposite side. So sometimes usually it gives a facial process which winds backwards, covering scalenus anterior, scalenus medius and levator scapulae muscles, and disappears beneath trapezius, forming the floor of the posterior triangle. So if you observe here, roof of the posterior triangle is formed by investing layer, whereas floor is formed by the prevertebral layer. So cervical and brachial plexus lie beneath this fascia. So between scalenus anterior and medius, the muscles, this fascia gives rise to a tubular axillary sheath around cords of brachial plexus and subclavian artery. So this is the possible route when there is abscess behind the prevertebral fascia. This can trickle down to axilla through this axillary sheath. You can see here, this is the investing layer beneath the sternomastoid. You can see the facial process arising here from the prevertebral fascia. This also forms the posterior wall of the carotid sheath, and you can see this is enclosing the prevertebral muscles and the vertebrae. Okay, so now if you see between the pretracheal layer and prevertebral layer, you can see this space is forming the visceral compartment, and within the carotid sheath, you can see this is the neurovascular compartment. So here also you can see this facial process which is coming back, covering the scalenus anterior, medius and posterior muscles, forming the floor of the posterior triangle. This is the roof of the posterior triangle. This is the floor of the posterior triangle. So prevertebral fascia vertical disposition. Above it is attached to the base of the skull. Below, the anterior layer, otherwise called alar fascia, blends with the buccopharyngeal fascia, covering constrictors of the pharynx. So anterior layer below blends with the buccopharyngeal fascia, which covers the constrictors of the pharynx. The posterior layer enters the thorax, blends with the anterior longitudinal ligament of the upper three thoracic vertebrae. So vertical disposition, when we trace, above, this prevertebral layer is attached to the base of the skull. Below, it has two layers. The anterior layer, otherwise called alar fascia, blends with the buccopharyngeal fascia, which covers the constrictors of pharynx. Whereas posterior layer enters thorax and blends with the anterior longitudinal ligament of the upper three thoracic vertebrae. Now, important points after disposing these three layers like investing layer, prevertebral layer and pretracheal layer. If you observe the carotid sheath as I shown in the diagram, it is formed by pretracheal layer and prevertebral layer. The axillary sheath is formed by the prevertebral layer. The spinal accessory nerve passes between the investing layer, that is the roof of posterior triangle, and prevertebral layer, that is the floor of the posterior triangle. Then dorsal scapular nerve, long thoracic nerve and phrenic nerve pass beneath prevertebral fascia. The cervical part of the sympathetic chain lies behind carotid sheath but in front of the prevertebral fascia. The recurrent laryngeal nerve passes behind the ligament of Berry or rarely pierces this ligament in tracheoesophageal groove. I have shown earlier in the diagram. If you observe, see here, this is the recurrent laryngeal nerve passing behind the ligament of Berry. Then retropharyngeal space lies between buccopharyngeal fascia and the prevertebral fascia. So now let us see the carotid sheath. So one of the most important neurovascular compartment in the neck. So it is a tubular sheath. It is a tubular sheath. Extends from base of skull to arch of aorta. Contains common carotid artery, internal jugular vein, and vagus nerve. If you see this relative position, artery will be medial, the vein will be lateral, and vagus nerve will be between and behind them within the carotid sheath. The sheath is thick over the arteries and thin over the veins to allow expansion when there is increased venous return. The anterior wall is formed with the pretracheal layer, and there will be incorporation of ansa cervicalis in the wall. And posterior layer, it's formed by the prevertebral layer. Structures piercing are the external carotid artery, tributaries of the internal jugular vein, glossopharyngeal nerve, spinal accessory nerve, hypoglossal nerve, cervical branches of the vagus nerve. So what is the most clinical important of this is the block dissection of neck during surgical removal of the deep cervical nodes. We have to be very crucial when we are dealing with the nodes around the carotid sheath, because most important blood vessels, the internal carotid, common carotid arteries and the internuclear vein are in relation to the carotid sheath. Then retropharyngeal space, it is a potential space. That means it is not visible in normal situations, but when there is accumulation of abscess, then it is visible. So that's why it has the potential to accumulate something. It is a potential space, allows expansion of pharynx during deglutition. So in front, it is by the buccopharyngeal fascia, which covers the constrictors of pharynx. Behind it is the prevertebral fascia. On each side, carotid sheath and its contents. Above, it is the base of the skull. Below, it is open, continues with the superior mediastinum of thorax. The contents are retropharyngeal lymph nodes, loose areolar tissue, and pharyngeal plexus of nerves and vessels. So, what is the clinical implication here? So, pus in the retropharyngeal space, it can extend into the mediastinum because it is open. It is directly continuing with the mediastinum. So, it can extend laterally behind carotid sheath to reach sternomastoid. It will be seen as a paramedian swelling in posterior wall of the pharynx. Okay. Why paramedian swelling? Because there will be a midline septum extending between buccopharyngeal fascia and the prevertebral fascia. If pus collected behind prevertebral fascia, so then we call it as cold abscess. We call it as cold abscess due to caries of the cervical spine, may be seen as median swelling in the posterior wall of pharynx. So pus may appear in axilla. Pus may appear in axilla. Pus may appear in axilla following axillary sheath, which was a tubular sheath around the cords of brachial plexus and subclavian artery and axillary artery. So you can see here, this is the retropharyngeal space. See, it is in open communication with the mediastinum of the thorax. You can see here, this is the buccopharyngeal fascia. So these are the constrictors of pharynx. You can see this is the anterior layer, which is in continuation with the buccopharyngeal fascia. This will be the posterior layer, which is the actual prevertebral layer. So you can also see here, this is the buccopharyngeal fascia. This is the constrictor. This is the buccopharyngeal fascia. This is the prevertebral fascia. You can see here. So this is the midline septum dividing the retropharyngeal space into two halves. So if there is a pus collection in the retropharyngeal space, so definitely it will be a paramedian swelling. If the pus is collected behind the prevertebral, then it will be a midline swelling. You can see here, this particular area, you can see this is the lateral pharyngeal space, lateral pharyngeal space. So lateral pharyngeal space on each side of the pharynx, you can see here, this is the pharynx. On each side of the pharynx, you can see the lateral pharyngeal space. So it is wedge-shaped space. Base is above, that is close to the base of the skull and auditory tube. Apex is below, up to the level of hyoid bone. So medially, it is having pharynx, palatine tonsil in the tonsillar fossa. You can see this is the pharynx with the tonsil in tonsillar fossa. Posterolaterally, parotid gland covered by the deep layer of parotid fascia. Anterolaterally, medial pterygoid muscle and ramus of mandible. So posteriorly, carotid sheath and its contents separated by styloid process and styloid group of muscles. You can see here, carotid sheath and its content posteriorly, along with the styloid process and styloid group of muscles. This is the laryngeal, lateral pharyngeal space. So you can see the carotid separates retropharyngeal space from the lateral pharyngeal space. Actually, it is the carotid sheath. Carotid sheath separates the retropharyngeal space from the lateral pharyngeal space. So contents are branches of maxillary nerve and maxillary vessels, fibrofatty tissue. So infection from this space may spread to multiple areas, like it can reach the submandibular region, it can reach the parotid region. But primary source for this space, that is the lateral pharyngeal space, will be the infection from palatine tonsil. You can see here, this is the lateral pharyngeal space. This is the palatine tonsil, close proximity. So tonsillitis and abscess in relation to the tonsil can easily reach this lateral pharyngeal space. From here, this can travel below to reach the submandibular gland, or it can reach to the neighboring parotid gland. Thank you.